down here how much I respect the contribution that she's made both in Canada, and then I think you were lucky that she left Canada and came to the United States. She was one of Syriax's girls. This was like when there was no such thing as discrimination. Syriax would only bother with women, okay, and that's all he would treat, apart from one guy who he taught that probably subsequently we kind of all realized was probably gay. And so it's kind of an interesting sort of thing that Syriax really sort of didn't really teach people like me who was, you know, going through them. It was a great sorrow to us, although we were allowed to go on his courses. I don't know that he ever identified very much with the males in the profession. Chris, I think, is illustrating a very important thing about the North American Institute, insofar as we have tried not to become too doctrinaire. And Chris is bringing a unique experience to us from the system in the Netherlands, and he's going to present some things that are very much of an interest to him on the course as we develop. I'd also like to thank David Link for the immaculate stuff that he does. If it were up to us, you'd probably be getting scruffy bits of paper photocopied. What you get from him is a very professional looking thing, and as far as we're concerned, it's so easy. We just send all these scruffy pieces of paper, and then I'm absolutely amazed that this kind of thing comes out. Because one of the things that I think has been important to us in the development is that all of the teachers within our system are essentially clinicians, and that's what we make our money at doing, at being clinicians. So the teaching is kind of like a sideline, and of course you're trying to produce stuff by working in the evenings, or in terms of trying to get your receptionist to do some of the things, and they're already doing other stuff, so you tend up to sort of put it through yourself in the evenings. And so it's very, very nice to be able to send stuff to Dave and have it come out like this. Plus the fact that when I look at some of the videos that come forth, they always look much better than I think they should look in terms of what's gone on in the group. And that's been a very, very important aspect, that you can look at different instructors. Now, we've all got our slight differences, both in the way that we conceive of theory and also in the way that we conceive of what is really important. And we've tried to encourage that. We really believe that what we're doing when we look at neuromuscular skeletal dysfunction is to try to develop a synthesis, looking at how can we discover what various dysfunctions are, and then how can we at least make some difference to these dysfunctions. Now, in terms of what's out there, there's a lot of approaches. Some are very doctrinaire. We've tried to follow that Tom Peters principle very much. The principle that he writes in his book on excellence, or I can't remember which one it is, or thriving in chaos, where he says that successful companies do not follow this particular principle, but follow this principle here. That means that if we haven't invented it, not invented here, we don't do it. That's what some places do. They're very doctrinaire. You follow this system, else you're not part of our group. I think that's nonsense, and I think it's dangerous. What we should do is follow this principle, which means swiped from the best with pride. So we look at what we're doing, and sometimes there are inadequacies in what we do. And we know that it's not very good, but it's the best that we've got at the moment. And then perhaps somebody comes along who looks at this in a slightly different way and offers a totally new perspective to us. Now we should embrace that, get good at it and embrace it and add it to our synthesis. Now, it's very important that we're not trying to produce little clones of whoever's doing the instructing. You will have your own synthesis as well. Hopefully it'll be based upon very good principles. It'll also be based on very excellent ways of proceeding with various technical various technical techniques. And then you can put that together as it is comfortable for you. And I think that's what's really very important. Unfortunately, in the neuromusculoskeletal field, there's a lot of things that seem to me, and perhaps this is a prejudice, seem to me to be somewhat fringy. And I think that there is so much in this that there is physiological background for, that we don't need to get too far out on the fringes of possibility. I'm a great believer in the principle that if you have something that is absolutely extraordinary in terms of what your claims are, you'd better have very extraordinary evidence that what you're doing is correct. And it seems to me that a lot of the time we tend to find people come out with a theory and it's as if they are reinventing the wheel, and if you just go back 20 years, somebody was doing it then. And very often these people that were doing it then never ever get mentioned. And I think this is a great shame. I think we should really celebrate the background that we've come from. If it's a manual therapist or a physical therapist that the information has come from, we can be doubly proud. But if it's come from anybody, we should acknowledge those particular things. I was presenting a small talk within a seminar a couple of weeks ago, which I was reluctant to do somewhat. But this was the Workers' Compensation Board in Alberta. Were trying to look at the interrelationships between the various provider groups. So that there were medical doctors, and there were physical therapists, and there were chiropractors, and then there were a number of people such as industrial nurses, occupational nurses, and so on. And it was amazing to me listening to some of these presentations where people were putting forward ideas that were actually picked up from sources that were never ever mentioned. And it's amazing to me that people do this, because I think if we can celebrate where it came from, it gives some recognition to the people that thought about it, and it also gives us some credibility that we're not just lifting ideas from other people. So I will try the very best I can to tell you where all this information comes from. So that if we look at a synthesis, which is obviously an amalgamation of a number of ideas, we can say right from the start that we have a number of major contributors to the way that we have tried to think about manual therapy. And it would be remiss if I didn't mention these by name. Certainly Dr. James Cyriax is a superstar in this kind of field, or was a superstar in this kind of field. A difficult man whose manner really alienated people. And the Chartered Society in Britain didn't really get onto the Cyriax bandwagon because they were very concerned about what the attitude of doctors out there would be if we in fact totally embraced Dr. James Cyriax's work. But there is no question that Cyriax really gave a position to his physical therapists. He believed in them, he believed in their opinions, and he promoted that idea. So with no doubt that Cyriax is a major figure as far as we're concerned. Now, as far as this course is concerned, and this might be a little different if it were some of my other colleagues teaching this course, I have been very heavily influenced by the Norwegian system, originally by Kaltenborn, and particularly over the last 20 years by Olaf Evjenth. And you will see a lot of Evjenth's ideas in the things that we will do. All of us, although I don't use the techniques particularly, but the conceptualization is important, and some of the principles that have been promoted by Jeff Maitland in Australia. And I'll try and show where his ideas come into this particular system. Now, If we look at the most well-known manual therapist in the world as far as orthopedic surgeons are concerned, it would probably be Mackenzie. He has been named more in Spine magazine and in various other orthopedic journals than any other physical therapist, without question, in the last 4 or 5 years. And Mackenzie protocol or Mackenzie exercises or whatever are kind of well known to orthopedic surgeons. Unfortunately, they use the term a little bit like they use the terms Williams exercises, without a knowledge of what the whole protocol is. But certainly we can look at some of the Mackenzie principles, although this is certainly not going to be a Mackenzie course, to tackle certain of the difficult deviation problems. Now, from other sources, I think it would be remiss if we didn't mention people like Karl Lewit from Czechoslovakia, who has really identified a total composite of approach, particularly the use of muscle-based techniques. And this would be complemented, of course, by the work of Mitchell from the osteopathic school, which we will go over some of these principles in terms of the terminology and the management of the muscle energy approach to looking at dysfunction. If we take muscle, which is kind of a neglected organ or system, in the sense that we all came from being muscle mechanics, didn't we? And then you hear about joints. So what happens is we all swing over and totally concern ourselves with movements of joints. And then when we found out about the difference between osteokinematic principles and arthrokinematic principles, it gave a further kick to the pendulum further over. Now the whole thing has sort of come back, and we've got a much better balance, I think, now, between looking at what happens within the dysfunctional segment, not only with muscle and joint, but also fascia and skin and the sort of neural motor that energizes all of these structures. And if we think in terms of that, then it would be a little bit remiss if we didn't mention people like Chan Gun, who has done a lot of work on the neuropathic effects of pain. Maybe a theoretical conceptualization, but it seems to fit our ideas of what we find. Now then, in terms of muscle, and we'll spend some time looking at muscle, and I'm sure from your background we'll be able to get a lot of contributions, because this is what's nice about this kind of course, at this level, and also at the manipulation level, that everybody's very experienced. And so we've got a lot of brain power here. And it's not just from me or from Anne or from Chris or from Anne or whatever. This is from all of us, that we want to sort of get out the best thing so we can all share each other's experiences. But one big figure in terms of muscle is Vladimir Janda. And we sort of have incorporated certainly his ideas of phasic and static muscle dysfunction and group dysfunctions, which we can consider a little bit later. Now then, coming into this field is perhaps a figure that you might not be aware of, but I'm going to promote. I don't usually promote things, but on this course there are two of these three things that I've come across that I think are so useful that it would be very remiss if I didn't sort of share this. And certainly a lot of the stuff on peripheral joints will be coming from this source. And this is a physical therapist who then became a teacher, trained in the British system originally, and a British teacher, so he's kind of like about 10 years younger than I am. Then he went, while he was doing his teaching, did medicine, then he did orthopedic surgery. Now he's a full professor of orthopedic surgery and very well thought of. He was also an international athlete at a weightlifting sport. And he has produced a book which I think should become our standard textbook on peripheral joint dysfunction. It's essentially athletic, but there is so much in this book that would fit any kind of practice. This is this book by David Reed here. Now, I've taken the liberty to write to Reed, and I got him to send me an envelope in which there are a number of postcards. So you can take a postcard, you can write it off to Livingstone, you can get this for 30 days at no risk. I sound like don't I? Like an infomercial here. But I will leave this book at the front here, okay? This is, I think, one of the greatest books. It's on the top 10 seller list, evidently, in medical books at the moment in North America. And you've probably not even heard of it. Just wonderful. I'll leave it here all week, and you can look at it. And a lot of the stuff that I will use when we get on to looking at the peripheral joints will be from tables that we have got from out of this book. It's a magnificent text. So, I will leave this here. Please look at it and see how good it is. And I will leave some of these little cards for you. See how easy I'm making it for you? Only available in the United States of America, this offer. Okay? But I think you'll find that it's an expensive book. It's $129, $175 in Canada. But I still think when I look at a man's lifetime's work in a beautiful text, that it's got to be something that will make us so much better than we are at our starting point. So, there it is. Here are the things, and I would certainly, take up this offer, and if you don't like it, send it back, because that's no risk to you. Okay, so I'm going to put Reed's name on here now. And so, if we look at this kind of approach, we can see that from here, we must have got a variety of ideas. And this is not an exhaustive list by any manner. And in the United States, you have got various systems going on, and each of those systems have kind of lifted material from other systems, sometimes not acknowledging it particularly, sometimes being a little too doctrinaire for me, that's for certain. Because I don't know that out there's necessarily the best way of going about this. What might be the best for you might not be the best for me. I think you've got to have things that suit the way that you look at patients, very much so. Some of you will like manipulating, perhaps, much more than you like going through mobilization procedures. I think we've got to sometimes try and restrict our natural. Very often we find problems that we want to find. One of the greatest things in medicine is going to a physician, giving your kinds of signs and symptoms, and they come up with their favorite diagnosis. And so we need to not just couple in, if we're myofascial people, this is just myofascial restriction. It might be. But there may be some reason, such as a joint that is suffering from some spondylitic change, which is giving neuropathic origins to stimuli along that nerve root, which is then affecting, either in the posterior or the anterior primary rami, the structures that are supplied by those things. And so, where do we start with this? Well, sometimes we start with what our favorite is, and sometimes we never get beyond that because we've kind of got too focused. And I think this is what we have to be very careful of, that even though you do have your favorite things to do, then we must really make sure that we still remain very comprehensive. Have you ever been on a course and somebody comes up with some strange syndrome that you never heard of, and the next week you find 10 of these? And then 6 months down the line you suddenly think, where are all these syndromes that I found in that first week? And you haven't found any anymore. Perhaps because you haven't been looking for them, or perhaps in that first week you focused your attention too much and you found a set of things that conveniently fitted this particular syndrome. And of course, the more experience we get, the more difficult the patients that we get often are. It's a disappointment to me that my results have gradually got worse over the years. And I get more frustrated. Had a really bad experience yesterday. I fortunately corrected the situation, but I would have felt really, really badly, and I'd have felt guilty all week. Had a woman that rang me at 7:15 in the morning to say, I'd seen her the day before, she was walking like this, and she hadn't moved from this particular kind of walk for the 3 weeks previous. And she rang to tell me that she was feeling quite sore after the treatment, she was feeling quite sore before the treatment, and that there was a certain amount of nausea, and she didn't think she should come. And did I know what the problem was? So instead of being kind of calm, I said to her, look, if you have no confidence in what I am doing, then I think it would be very wise for you not to come. And then she realized that I'd picked up a meta message from her, which wasn't the correct message, and she tried to correct it, and I didn't allow her to do this. I was really cheesed off. Having treated 3 or 4 areas for her, a thoracic spine, a cervical spine because she'd been like this, as well as the lumbar spine, and so we decided that she wouldn't come in. Now, here's a woman that told me the day before that she'd left her husband and she's now in the shelter for abused women. She didn't need this abuse from me. So I sort of let this run around my brain for about 15 minutes, feeling really badly about this whole thing. So I got my receptionist to ring the shelter, and I just asked her to call me again if she wished to speak to me. So she called, and I sort of apologized and said, I think we got off on the wrong start here. This is what I should have said to you. And I just explained the thing, and she said to me, well, can I come down now? And of course I saw her, and everything was sort of settled down. But sometimes, you know, this personality thing of ourselves too gets involved in this. And I think we've got to be really careful that we are providing a sort of a healing environment as well as just a technical healing environment. So I'm glad I corrected that, as I should have been feeling really guilty all week about this particular person. So, what's this course going to be about? It's a lower quadrant course, which means that we're going to have to look at the lumbar spine and the pelvis. And then we're going to take certain aspects of dysfunction as far as the lower limb is concerned. Now, the special things and different things as far as the peripheral joints in the lower quadrant are concerned for a lower quadrant course is that we do have to do the high velocity manipulative movements as they are appropriate in the lower limbs. One of the things that we've always felt, and this was a thing that I was asked in this particular thing by a chiropractor, I've done 4 years solely concentrating on manipulation. Do you think that you should be doing it when I know you haven't? My sort of answer to this arrogance was that the way we do it is different, and the system that we have is highly thought of, and it is non-doctrinaire, and we do not think that people should learn to manipulate the spine until they can mobilize the spine correctly with locking and also manipulate the peripheral joints. Do you know all about that? And there was no reply. So what we've tried to do within the whole of our training, and this is largely the sort of IFOMT suggestion too, that people should go through this training of learning semi-specific mobilization, mobilization to the periphery and then to the spinal joints, and then learn manipulation of the peripheral joints before we go on to manipulation of the spinal joints. And I think it stood us in very good stead, because if you look at the kinds of problems we ever get from manipulation courses, they are very, very small. Most people don't feel anything like as sore after a manipulation course of the spine than they do after muscle stretching courses, myofascial courses, mobilization courses, and so on. And I think that's a credit perhaps to the system, but also to the people that are coming on the courses who have developed the kind of skill levels necessary for them to get to that level. And of course, you've had to prove your competency by examination at this mobilization and manipulation of the periphery before you get to that stage. And I think it stood us in very good stead, that particular system. And I think it's defensible, and I think it's going to need to be defensible, because I can see from the way that chiropractors are developing that they want to produce themselves as the kind of conservative specialists of neuromuscular skeletal dysfunction. And I think if they could get away from some of the kind of evangelistic things of having a whole healthcare system based on the spinal lesion, they would be much more acceptable within the normal medical community. And where does that leave us? So I think we've got to be very much in the forefront, very proactive in the way that we are tackling this. The chiropractors in Alberta at the moment have asked for a meeting between the private practitioners in physical therapy and also between the college, ostensibly because relationships have not always been too good between the two colleges. I would look for a different message and a different agenda, and perhaps I am doing them a disservice. But I would think that they are going to make certain suggestions, such as physical therapists should not manipulate the spine, for example. This happened in the state of Washington here, didn't it? That we will support your claim for open access if you will not do manipulation techniques. And of course, we all know that many of the times this is a totally dead issue, because it's all right having open access, but if the paying agencies won't pay unless you've got a medical referral, where does it leave you?